This conference will now be recorded.
Good morning, students. Good morning, students. Hope you're all doing well. So today, there's a last topic in the entire female genital tract. There is the disease of pregnancy. So we will complete this topic today. And the entire topic of female genital tract will be over with this class. So I will be taking another chapter soon, according as per the schedule. So please focus. This is very, very important topic as far as your undergraduate exam is concerned. Of course, your MD entrance or MS entrance is concerned. There are good number of MCQs will come out of this topic. Okay. So, and in general practice also, this is very, very, very important topic with those who become future gynecologists or future obstetricians. So this topic is very, very, very important. So please focus. Please pay little attention. Relax. And just see, and I will share anyhow. I will share my PowerPoint later on. Okay, so let us see first. So for any topic, before we start, actually we think first inflammatory conditions, later on the traumatic and neoplastic conditions. Okay, so this topic we start with the inflammatory conditions. So let us. So the placenta. So the infection will reach the placenta by two ways. One is by ascending infection via the female genital tract, and another one is by the hematogenous dissemination. Okay, so let us first see the more common ascending infections, which are mycoplasma, of course fungus candida, and of course the numerous bacteria which are there in the vaginal flora. Okay, so you all know that vagina will have a lot of bacterial flora. Okay, there are a good number of bacterial flora. So because of when good number of bacterial flora is there, you won't get any trichomonas, or you won't get any other bacterial infections. Okay, so during pregnancy, what happens is because of hormonal influence, there is every chance of hormonal disturbances. So there is a disturbance in the normal bacterial flora, and abnormal bacteria will grow within the vagina, and that will ascend into the uterine cavity and of course the placenta. Okay, so resulting in what? Premature rupture of the fetal membrane. So this is one of the most common complication we encounter in the third trimester of pregnancy. There is a premature rupture of the fetal membranes, resulting in preterm delivery. Okay, it's very, very important point actually. Ascending infections, the placental infections. So because of preterm delivery, the baby will face a lot of problems, and because of premature rupture of membranes and of course early delivery, and there will be the mother also will take little time to recover. Okay, baby won't have any breast milk also. So actually this is the reason we should take care of these inflammatory conditions during pregnancy. So what happens? So when the bacteria will ascend in the female genital tract, initially there will be inflammation of the chorion and amnion, the layers which are surrounding the fetus. So usually we get fetal autopsies. So because of unusual deaths in the third trimester, so we take few bits from the membranes and we look for any neutrophilic infiltrations there. So we also take from bits from the placenta and umbilical cord to look for any infectious changes like villitis and phenycitis, all those things. Okay. So what happens in acute chorioamnitis is the chorioamnion shows neutrophilic infiltration associated with edema and condition. Okay, this is called as acute chorioamnitis. So this is because of the ascending infection from the female genital tract. Okay, sometimes infection may involve the umbilical cord and of course the placental villi, resulting in acute vasculitis of the cord, which is called as phenycitis and villitis. So please be familiar with this terminology. The vasculitis of the cord, umbilical cord, is called as phenycitis, and the villitis, the placental villi which are there within the placenta, may also show inflammation resulting in villitis. Okay, so please be familiar with this topics, with terminology. The second uncommon route of spread is hematogenous spread. Okay, what are the bacterial infections which can occur by hematogenous route? Is one is syphilis, second is tuberculosis, third is listeriosis, fourth is toxoplasmosis, and various viruses like rubella, cytomegalovirus, herpes simplex, all can cause placental vulnitis by hematogenous spread. Okay, so transplacental infection also can affect the fetus and give rise to the torch infections like toxoplasma, rubella, cytomegalovirus, and herpes complex. Okay, this transplacental infection also can affect the fetus, and in all this, so here actually the placental villi are the most commonly affected. So we call it as a vulnitis. So I already emphasized regarding this terminology. So we have to remember the torch infections, and if we have to remember the terminology used here, the inflammation of the villi is called as vulnitis, and the vasculitis of the umbilical cord as phenicitis, and inflammation of the choriamnion is called choriamnitis. Okay. So please remember these points, and because of these infections, there is every chance of premature rupture of membranes and resulting in preterm delivery and bad maternal recovery. Okay. So please do remember these points, which are very important regarding the placental inflammations. Next, we'll go to the most commonly seen topic is entity is ectopic pregnancy. Ectopic pregnancy. Every day I used to get one case of ectopic pregnancy in my pathology laboratory, because very common this is. This is because of an implantation of fertilized ovum in any site other than the uterus. This is nothing but an ectopic pregnancy. Normally, everybody knows that there is a uterine cavity. The body of the uterus will bear the growing fetus. Okay. So sometimes what happens is the ovum, the fertilized ovum, won't reach the uterine cavity, and it will be stuck somewhere within the fallopian tube or sometimes to the abdominal cavity. Okay. So approximately 1% of pregnancies implant ectopically. The most common site is the fallopian tube. The reason being the normal anatomy of the fallopian tube is abnormal because of childhood salpingitis, childhood chronic salpingitis. It results in scarring. So whenever there is a salpingitis, whenever there is inflammation of the fallopian tube, so because of the childhood infection, it results in scarring of the fallopian tube. Once there is a scarring of the fallopian tube, there is a problem regarding the motility of the fallopian tube. So because of that, the fertilized ovum won't reach the uterine cavity, and it will persist within the tube, fallopian tube, and it grows within the fallopian tube as it grows within the uterine cavity. So because of that, the size of the fallopian tube, wherever it gets the ovum stuck, it will be enlarged, it will be globular, enlarged, and it will result in a lot of hemorrhage within the fallopian tube. And sometimes the fallopian tube will rupture, and the ruptured ectopic will then go inside the abdomen. And most of the times, because of the rupture, the women do come to the emergency because of the ruptured ectopic pregnancy. Okay, so if you don't treat that ectopic pregnancy, what happens? It results in exsanguination and death. Okay, so that's why the scan in the first trimester is recommended, whether the gestation is within the endometrial cavity or somewhere else. This is the reason why the scan in the first trimester. Of course, one is this. The second thing is that to rule out Down syndrome. So this also, the congenital, the early, we can detect the Down syndrome in the first trimester scan. So if you detect any abnormality, anomaly in the early trimester, what we can do termination early. So it is very difficult in the second or the third trimester. That's the reason why we advise a scan in the first trimester. Next important point is gestation within the abdominal cavity occurs when the fertilized egg drops out of the umbilical of the oviduct duct and implants on the peritoneum. Okay, so this I have never seen in my last 10 years of experience. Some senior gynecologists might have seen this abdominal gestation within the abdominal cavity. So in my last 10 years of experience, I never seen a case of ectopic pregnancy within the abdominal cavity. The next important and most important topic is the gestational trophoblastic disease, which is divided into Hydatidiform mole. Please note the spelling. Hydatidiform mole. Hydatidiform mole. Okay, don't write Hydatidiform mole. Just some, because we have a one more topic called hydatid cyst. So because many of the students are confused with Hydatidiform mole with hydatid cyst. Okay, so please, so this, you note down the spelling. This is called as Hydatidiform mole, and other important topics like invasive mole and choriocarcinoma. So moles are most common before the age of 20 years and after the age of 40, and the history of the condition increases the risk for molar in subsequent pregnancy. Okay, so please make a note of it. So it is very common in the early and of course after 40, and if there is a previous history of molar pregnancy, there is every chance of getting molar pregnancy in the subsequent pregnancies. So what is the clue for this type of diseases is an extremely elevated HCG levels, which can be detected in the blood and urine, and considerably higher than those found during the normal pregnancy. So you know that normal pregnancy HCG will be elevated because of the cytosynthesis or trophoblast of normal placenta. But in these patients it will be abnormally elevated. In this patient it is abnormally elevated. Please remember. Okay. So let us take for the Hydatidiform mole. So the typical Hydatidiform mole is a voluminous mass of swollen, sometimes cystically dilated. So this is the pic, you can see. So numerous swollen villi appearing like a grape. So this is how it looks grossly, the complete Hydatidiform mole. This Hydatidiform mole is divided into complete and partial. So the complete will have the cystically dilated chorionic villi, which is appearing as grossly grape-like structures, and the swollen villi covering by varying amounts of the normal to highly atypical chorionic epithelium. And so let us take first the complete Hydatidiform mole. So it is not compatible with embryogenesis and never contain fetal parts. And all of the chorionic villi are abnormal, and the chorionic epithelium is also diploid, and they are paternal origin. So that's why we'll have a 46 XX or uncommonly 46X and Y. So one may be derived. So actually this is of paternal origin. So you won't get this is completely from a paternal origin. You won't get from a maternal genome. The partial Hydatidiform mole is compatible with early embryo formation, and therefore may contain fetal parts, and has some normal chorionic villi, and is almost always triploid. Okay, that's why here karyotype is 67 XY. Why this? How this triploid has came? How this triploid came in complete? I will tell you in the next slide. See, in complete mole, the entire genetic content is supplied by 2 spermatozoa or a diploid sperm, yielding diploid cells containing only paternal chromosomes. Okay, whereas in partial mole, a normal egg is fertilized by 2 spermatozoa or a diploid sperm, resulting in a triploid karyotype with a preponderance of paternal genes. Okay, so here, so there is a ova, and of course the 2 sperms or a single sperm which was doubled. Okay, this results in partial mole. Whereas in a complete mole, what happens is an empty ovum will be united with a diploid sperm. Here only you will have a paternal chromosomes, so you will not find any maternal chromosomes in complete mole. This is what I'm saying here. All of the chorionic are abnormal, and the chorionic epithelial cells are diploid. Okay, so this is the difference you should keep in mind, and this is the essential differences between complete and partial Hydatidiform mole. So this may be asked as either 4-marks question or a 2-marks question. So please do remember this table. So the differences between complete mole or a partial mole, or sometimes the entire topic of Hydatidiform mole may come as 4-marks question. Okay, so in a complete mole, the karyotype is 46XX or 46XY. In partial mole, the karyotype is triploid with 69 XY. So villus edema is seen in all villi in complete mole, whereas in some villi it will be shown in partial mole. The trophoblastic proliferation is diffuse and circumferential in complete mole, where it is focal and slight in partial mole. Sex is elevated in complete mole, and it is elevated in partial mole. And tissue ACS is very much elevated in complete mole, and it is less elevated in partial mole. And risk of subsequent carcinoma is 2% in complete mole, whereas it's rare in partial mole. Okay, so all the differences you should remember. One is karyotype, second is villus edema, Third is trophoblast proliferation. Fourth is serum SCG. Fifth is tissue SCG. Plus have subsequent choriocarcinoma. So this is the gross picture I have shown you previously, and this is how the microscopic looks. You can see the villi, cystically dilated chorionic villi with a lot of central hydrophic regeneration, and they are lined by simple cuboidal cytosynthetic trophoblasts and few multinucleated synthetic trophoblasts. And you can see there's a marked cytosynthetic trophoblastic proliferation surrounding this villi. Whereas in partial moles, villus edema involves only some of the villi because the other villi are normal, and trophoblastic proliferation is focal and slight. The villi of partial moles have a characteristic irregular scalloped margin. In most cases of partial moles, some fetal cells are present, ranging from fetal red cells in placental villi to a rare case of a fully formed fetus. Overall, 80 to 90% of moles do not recur after thorough keratase, and 10% of complete moles are invasive, and no more than 2 to 3% give rise to choriocarcinoma. So these are the few important prognostic points you should remember. So both for the complete mole and the partial mole, the treatment is keratase, and most in 90% of the cases they won't recur, but in 10% they may become invasive, but in 2 to 2% of cases they may become malignant, resulting in choriocarcinoma. So next topic is the invasive mole. So why we are saying invasive? Because the molar pregnancy which was there before has gone beyond the endometrium into the myometrium, sometimes even beyond it. Okay, that's why we are saying it as an invasive mole. It's locally invading. Okay, but it does not have an aggressive metastatic potential as that of a malignant molar pregnancy that is called as choriocarcinoma. So malignant gestational trophoblastic disease is the choriocarcinoma. So it retains the hydrotic villi, what we have seen complete mole or partial mole. So we'll have a similar type of villi will be seen in invasive mole, but what is important is they penetrate the internal deeply, possibly causing rupture and sometimes the life-threatening hemorrhage. So that's why we are calling it as an invasive mole. On microscopic examination, the epithelium of the villi shows atypical changes with proliferation of both trophoblastic and syncytial components. An invasive mole is difficult to remove completely by keratase if serum beta hydroxylase remains elevated, and in most cases cure is possible with chemotherapy. Okay, so actually suppose if the particular woman completes her pregnancy, I mean, like if she had 2 or 3 children, he doesn't want to have any pregnancy in future, so we can advise hysterectomy. So because of this invasiveness, we cannot remove by the normal keratase, which we do for a partial or complete Hydatidiform mole. Okay, so for these cases, what is I mean, if woman completes the family, then we can go for hysterectomy. Or if she is not going, I mean, if she wants to continue with the uterus, what have we advised that the chemotherapy. So this is the treatment for invasive mole. Next is the gestational choriocarcinoma. It's a very aggressive malignant tumor, arises either from gestational chorionic epithelium or less frequently from torti potential cells within the gonads. So we discussed this in the last class as a germ cell tumor. So because sometimes within the gonads we will have a torti potential cells which differentiate into choriocarcinoma. Approximately 50% of choriocarcinoma arise from complete Hydatidiform moles. About 25% arise from after an abortion, whereas remainder manifest after after a normal pregnancy. Okay, so this is the reason. So why this is the reason I should always so many things are not in our hands. We should always keep our fingers close and pray the Lord. Okay, even in normal pregnancy, sometimes you may have a choriocarcinoma. So that's the reason. So okay, take the elders' blessings and of course the God. In most cases, choriocarcinoma manifests with a bloody brownish discharge accompanied by a rising titer of beta hydroxylase in blood and urine in absence of marked uterine enlargement, such as would be unexplained. So in normal mole, we discussed so the uterine, I mean, the size of uterus is normal than expected in a molar pregnancy. So what happens in gestational choriocarcinoma is actually, even though the beta NCC levels are high both in blood and urine, the uterine enlargement is actually small. So, and of course, the beta NCC titer we discussed in the first slide itself are much higher than those associated with a mole, like it will be in thousands. Coming to the morphology, choriocarcinomas usually appear as hemorrhagic, necrotic uterine masses. Sometimes the necrosis is so extensive that a little viable tumor remains. Indeed, the primary lesions may self-destruct and only the metastasis tell the story. And very early, the tumor insinuates itself into the myometrium and into the results. In contrast with hydatidiform moles and invasive moles, chorionic villi are not formed. Instead, the tumor is composed of anaplastic cuboidal cytotrophoblast and syncytial trophoblast. This is the difference. So in hydatidiform mole, you'll see villi. So whereas in choriocarcinoma, you won't find any villi. And so there you may find little ATP here, but here you will not find villi, but you will only see the anaplastic cuboidal cytotrophoblast and syncytial trophoblast. The difference between hydatidiform mole and invasive mole is, in invasive mole, that you will see villi and the changes of hydrogenation, but what it will do is it will invade the uterine wall. That's the difference, and sometimes it goes beyond the uterine wall. So that's the difference with invasive mole and the hydatidiform mole. And the difference between invasive mole and the choriocarcinoma is, in choriocarcinoma you will not find any hydrotic villi. What you see is the anaplastic cyto and syncytial trophoblast. So you can see here, this is a case of choriocarcinoma. You can see the multinucleate syncytial trophoblast and few atypical cytotrophoblast. So come to the prognosis and treatment. By the time most choriocarcinoma is discovered, widespread vascular spread usually has occurred to the lungs, vagina, brain, liver, or kidney, and lymphatic invasion is uncommon in choriocarcinoma. So it is spread by hematogenous route. Despite the extremely aggressive nature of placental choriocarcinoma, these tumors are remarkably sensitive to chemotherapy. Nearly 100% of affected patients are cured, even those with metastasis at a distance such as the lungs. And second, so in the last slide we discussed that you will not find a normal, tissue, you will find only necrotic tissue. The reason being the maternal immune response. The maternal immune response against the foreign, like paternal antigens, helps clear the tumor by acting as an adjunct to the chemotherapy. Next topic is the placental site trophoblastic tumor. These tumors are derived from the placental site or intermediate trophoblast. These uncommon diploid tumors often have doublets in karyotype, typically arise a few months of pregnancy. Because intermediate trophoblast does not produce HCG, the large amounts, HCG concentration is slightly elevated, and more typically these tumors produce human placental lactation. An indolent clinical course is typical with a generally favorable outcome if the tumor is confined to the endomyometrium. These tumors are not as sensitive to chemotherapy as other trophoblast tumors, and prognosis is poor when spread has occurred beyond the uterus. So this is the pathologic situation with the placental site trophoblast tumor. So choriocarcinoma, even though it spreads by the time we detect, even though it spreads to lungs, liver, brain, etc., we can actually, it is chemosensitive and we can treat with chemotherapy. Whereas this placental site trophoblastic tumor, so actually it proliferates from the intermediate trophoblast, and actually it spreads slowly, but it's not sensitive to chemotherapy as the choriocarcinoma, and the prognosis is very poor with placental site trophoblastic tumor. And one more important point you have to remember is it produces human placental lactogen HPL rather than HCC. Okay, please do remember these points. So thank you so much for your kind participation. And this is the last and final class of the tumors of the disease of the pregnancy. So this class is very, very, very important class, because so you will definitely, invariably, you will get either 4 marks or 2 marks or a good number of MCQs. That's such a nice topic this is. Hope everybody understood regarding this. Any doubts you can ask me. You can post me in the group, WhatsApp group, and of course I will send the PowerPoint in the group. Okay. Thank you so much, and I also thank the management for providing this audio-visual aids to reach you during this COVID times. I thank everybody. Thank you so much.